there are many clinical trials that have read out in the early stage setting that have completely transformed the way we think about early stage lung cancer. Adjuvant targeted therapy with the AURORA trial, we know that osimertinib is already approved. However, recently we heard an overall survival update, which I'll share with you. We have 2 approvals for adjuvant immunotherapy, EMPOWER-010 looking at adjuvant atezolizumab, as well as the PEARLS trial or KEYNOTE-091 looking at adjuvant pembrolizumab. Both of these are approved and available. And the neoadjuvant chemoimmunotherapy, CheckMate 816, also FDA approved for 3 cycles of chemoimmunotherapy before surgery. And now we have 2 additional clinical trials that have read out, which use perioperative immunotherapy, that is pre and post, so neoadjuvant as well as adjuvant, AEGEAN and Keynote 671. So let's just go through many of these trials now. About 3 years ago, AURORA read out at ASCO 2020. This is a phase 3 double-blind clinical trial for patients with 1B to 3A non-small cell lung cancer with either an exon 19 deletion EGFR or L858R, only those 2 sensitizing mutations. Patients had to have had surgery and then were randomized. They could have received chemotherapy. They didn't have to. And they were randomized to either receive osimertinib or placebo. And the primary endpoint was DFS, as you can see on the right. Significant improvement with a hazard ratio that was 0.17 for the stage 2 and 3A population. So this led to an approval for osimertinib in December 2020, which made it really important for us to test for these patients in the adjuvant setting. Most recently, we saw overall survival data at this year's ASCO annual meeting, and you can see this is the first time that we're actually seeing an overall survival benefit with the use of an adjuvant targeted therapy in resected lung cancer, hazard ratio of 0.49. This is for patients with stage 2 to 3A disease. And then if we look at all included disease states, including 1B, 2, and 3A, you can see an overall survival again of 0.49. Overall survival benefits seemed to be across all subgroups. You can see sex, age, smoking history, race, as well as stage 1B and 2. You can see the confidence intervals kind of touch 1 for 1B and 2, and I think this is related to data not being mature. But regardless of adjuvant chemotherapy receipt, patients did benefit, and we'll talk a little bit more about this. Most of the patients, about 60% of the patients received adjuvant chemotherapy, about 40% did not. However, most of the higher stage patients, so if you look at stage 3, 80% of the patients with stage 3 did receive adjuvant chemotherapy. So in my practice, I'm going to continue to offer adjuvant chemotherapy because there is an overall survival advantage. Of course, I do want to give them osimertinib as well, but I'm not foregoing adjuvant chemotherapy. And then in terms of EGFR mutations, L858R did a little bit worse. I mean, they did benefit, but this has been known for many years based on the biology of these 2 mutations. Overall survival by disease stage is displayed here. And as you can see, stage 3A, significant improvement. You can see the separation of the curves is the most in stage 3A. And then, as we talked about a little bit, benefit was there irrespective of whether or not patients received adjuvant chemotherapy. Talking about immunotherapy, the first trial that led to approval of immunotherapy was the EMPOWER-010 study. Again, stage 1B and higher resected tumors were included. But this trial mandated the use of 1 to 4 cycles of cisplatin-based chemotherapy, and then patients were randomized. The statistics were designed in a hierarchical fashion, with DFS being tested first in the PD-L1 positive stage 2 to 3A patients, and then DFS in the all randomized stage 2 to 3A, and then finally DFS in the intent to treat population. What we found was that for the first analysis, that is PD-L1 positive stage 2 to 3A, there was a significant improvement in DFS. You can see the hazard ratio is 0.66. But as you keep diluting the population, so for example, if you throw in the PD-L1 negatives, which is the middle curve, the hazard ratio becomes kind of 0.79. And then if you throw in the stage 1Bs in there, the hazard ratio becomes 0.81. So really, I think the majority of benefit here was being driven by the high PD-L1 high stage tumors. The Pearl study was slightly different in that it did not mandate chemotherapy. Same stage 1B to 3A, these were all AJCC 7, complete surgical resection, and then patients were randomized to receive either 1 year of pembrolizumab or placebo. DFS in the overall population was the endpoint. Remember, DFS only in the PD-L1 positive population, as well as the stage 2 to 3A was the endpoint in atezolizumab and Empower. Here you can see DFS in the overall population on the left with a hazard ratio of 0.76. And then in the PD-L1 greater than 50%, you would expect a hazard ratio to be better. However, it was 0.82. And this is surprising. The curves are crossing. Maybe the control arm did actually quite well on this trial. So if we compare the adjuvant-only immunotherapy trials, Empower 010 is on the left, and Keynote 091 is on the right. Before this, I had shown you DFS data, and these are the overall survival curves. And as you can see, the overall survival with adjuvant immunotherapy is not that much, right? The hazard ratio is 0.99 for atezolizumab, and it's about 0.87 for Pearls. Data are immature, but we are not really seeing a big, huge signal for adjuvant immunotherapy leading to an overall survival benefit. Certainly not the same magnitude as we are seeing for targeted therapy. However, we now have another option. We have patients that can receive neoadjuvant chemoimmunotherapy. So for example, I have on the left here a paradigm of doing surgery and following it with immunotherapy, but on the right, we can actually come in with chemo and nivolumab for 3 cycles followed by surgery. And what you will see from this trial is, again, same population, 1B to 3A. They excluded EGFR and ALK. Chemo-IO or chemo alone went on to surgical resection. Primary endpoint, event-free survival. And here you can see much significant improvement in EFS with chemo-IO with a hazard ratio of 0.63. If we look at stage 1B to 2, maybe not that much EFS improvement, but in stage 3, hazard ratio is 0.54. And the same thing for PD-L1 expression. Almost all of the groups benefited, but of course, the PD-L1 greater than 50% benefited the most. This was not a powered analysis. This is a subgroup analysis, but this is something that we would expect, that the higher PD-L1s would benefit more. And then finally, I think the money slide here is that overall survival is better for those who received chemo-IO. Again, this curve, the separation of the curves is a little bit more than we're seeing with the use of adjuvant immunotherapy. So I think something to be said about dismantling the tumor microenvironment when the tumor is actually intact. So those were the 2 immunotherapy trials, and then one just the neoadjuvant trial. And now we have this perioperative paradigm where you come in with neoadjuvant chemoimmunotherapy and then you follow it with adjuvant immunotherapy. So there are 2 such trials. The first of them was presented at AACR called the Aegean trial, phase 3 global randomized double-blind treatment naive stage 2 to 3A, had to receive durvalumab plus platinum-based chemotherapy or placebo plus platinum-based chemotherapy. 802 patients randomized to these regimens and then went on to surgery. The neoadjuvant chemoimmunotherapy arm received durvalumab for another 12 cycles or for a full year. Primary endpoint was PathCR as well as EFS. And as we would expect, EFS was better with chemoimmunotherapy. Here you can see the blue line doing much better than chemotherapy alone. I don't think this is a surprise to us anymore. And what we are seeing is the same story in Keynote 671, Very similar trial. Again, here they mandated cisplatin-based chemotherapy alone. Same population, stage 2 to 3B, no prior therapy. They did not exclude EGFR and ALK, but they did mandate cisplatin, and patients could receive up to 13 cycles of pembrolizumab following surgery. We saw the same thing, event-free survival much better, hazard ratio of 0.58. But how does this translate into progression? How does this translate into overall survival is depicted here, albeit immature. You can see overall survival hazard ratio here is 0.73. Much greater separation of the curves than we are seeing with adjuvant immunotherapy. And pathological response rates seem to be high. I think about 18% with pembrolizumab on the right. And on the left, you can see major pathological response is shown there as well. And then if we look at exploratory analysis, patients with PAT-CR or without PAT-CR both seem to do better with pembro monotherapy after. You can see there's a difference in both sets of curves. So for patients who don't quite achieve a PAT-CR, maybe pembro is giving a little bit more push. And those patients who do achieve PAT-CR, maybe maintaining the same thing that led to the initial PAT-CR is actually helping. So remember, this regimen is currently not approved, but may be approved in the near future. If we were to compare the overall survival results for all these trials, the adjuvant trials are actually on the bottom. I would like to go through those first. And these are the Empower and Keynote-091. And you can see hazard ratios of about 0.9, 0.87. But if you look at the neoadjuvant Checkmate 816, overall survival looking promising at 0.62. We didn't really talk about NeoTorch. It's a Chinese clinical trial using a drug called toripalimab. But if we ignore that, Keynote 671 is also giving us a hazard ratio of about 0.73. So in summary, we have many clinical trials looking at targeted therapy, immunotherapy, and neoadjuvant, as well as perioperative strategies in the early stage setting. I think it's important for us to identify those patients that have a molecular target, such as EGFR, so that we can avoid immunotherapy and give them targeted therapy. I think testing for PD-L1 is very important. And I think finally, multidisciplinary management, where patients are seen by medical oncology in collaboration with surgery, so that we can appropriately define sequencing, which needs to come first. Should Chem-IO come first for everyone, or should it be a case-by-case based approach? Is really important. So I'll stop there, and happy to open this for discussion as well as questions.
So go ahead.
Sorry. Dr.
Question. Hi. In the trial where the requirement for adjuvant chemo was not there, was there a subset and an analysis where patients, if some of them had received adjuvant chemo versus just the immunotherapy, was there a difference in the response?
Yeah, so you're asking about adjuvant immunotherapy. So there wasn't much of a difference. Don't know if I have that slide. There is a forest plot on the Keynote 091 slide. Give me 1 second. Can you see this? I don't know if this is the forest plot. This is not the forest plot here. I don't have that slide in the slide deck, but basically there wasn't much difference in those that received adjuvant versus not adjuvant chemotherapy on Empower. In Empower, everyone was supposed to get adjuvant chemotherapy, so that one was not done.
Thank you.
I have a question. Since the neoadjuvant EP is approved, you prefer adjuvant or neoadjuvant checkpoint inhibitors?
I don't believe neoadjuvant IPI is approved in lung. It may be approved in melanoma. Do you mean Nivo?
Yeah, Nivo is approved in neoadjuvant though.
Right. So Nivo is approved. IPI is not approved.
Yeah.
Yeah.
No, I'm talking about Nivo, like checkpoint inhibitor, like a therapy. You prefer neoadjuvant approach or adjuvant approach? Because
Exactly.
the
So
whole idea is like a turning cold tumor into hot. You need to have some tumor cells. You have more
exactly.
tumor cells before surgery. And so what is your approach here?
Yeah, that's exactly right. So I think the data is evolving and we are seeing very minimal survival advantage with the use of adjuvant immunotherapy. I do think that given the fact that the tumor is intact, you're able to actually stimulate the tumor microenvironment with coming in with a chemoimmunotherapy approach may be more promising. However, having said that, we have the CheckMate 816 approval. I think it's a valid regimen for many of our patients with stage 3, maybe stage 2 with single station nodal involvement. I don't quite know if those patients with stage 1B, the old stage 1Bs, or stage 2 all uniformly benefit. So maybe there's a subset that can go straight to surgery. I don't think we've quite identified those yet. And then one more point I will make is that we don't really know what to do with those patients that don't get PAT-CR. They are the ones who are probably refractory to immunotherapy. And at the current time, we don't have an indication or an FDA approval in that setting.
Oh, if you use immunotherapy in neoadjuvant setting, you can't use it in adjuvant though.
Currently, there's technically no FDA approval.
Okay, thank you.
Yeah, great question.
So true, at Penn is it basically following along the lines that your stage 3s are moving towards a neoadjuvant approach and the stage 2s are sticking with a more traditional adjuvant approach?
So I think it's evolving even beyond that. I think all stage 3As are being discussed at our tumor board, and then we're obviously thinking of chemoimmunotherapy for these patients. I think even for stage 2s, with nodal involvement, we are considering chemoimmunotherapy rather than coming in with immunotherapy at the back end. Especially if somebody has a PD-L1 negative tumor, maybe we can give them chemoimmunotherapy, get a little bit more benefit rather than if they're PD-L1 negative, I don't have a lot of confidence that they're going to benefit in the adjuvant setting. So even for our stage 2s, Charles, we're moving towards more of a neoadjuvant paradigm, but that also means that we have to make sure that we test everyone so that I'm not inadvertently treating an EGFR mutant with chemoimmunotherapy in the neoadjuvant setting.
I got a question. All right, go ahead. Hello.
Yeah,
For-
go ahead.
Go ahead, Dr. Wu.
Yes, okay. In terms of Keynote 671, there is a stage 3B involved, eligible for the clinical trial, right? Do we have any data suggest the stage 3B any different in terms of compared to stage 3A? But stage 3B, some of the patients may not be able to directly resect it.
Exactly. So I think that has been a
So
huge
how
criticism.
many patients, what percentage of patients was converted into resectable from non-resectable before a neoadjuvant?
Yeah, that's a very good point. I think that has been one of the criticisms of this Keynote 671, as well as NeoTorch, actually, that many of the patients, or at least stage 3B, were allowed to be included on this Keynote 671 trial. The conversion rates, I don't know. What they shared was their percentage of patients undergoing pneumonectomy as well as the percentage of patients undergoing lobectomy, but we actually don't have information on downstaging. What we have is major pathologic response and PAT-CR. I think in the future, in sort of like the surgical section or the surgical follow-up for the paper, these things will come out, but we don't have it.
Thank you.
It's a great question. Dr. Ram, you have a question?
Yeah, I have a question for stage, very early stage small tumor. Can you avoid EGFR positive chemotherapy, or you still use chemotherapy in adjuvant?
Yeah, less than 4 centimeters, like 3 centimeters or something.
You straight go for osimertinib without giving chemo?
I think if we were to think about them in the new staging system, they would be still stage 1, stage 1A or 1B, depending on what size they are. If they're 1B or higher in the current stage, I think stage 2, I would definitely think about EGFR directed therapy. If they're node negative, I'm less inclined to give them chemo with a smaller tumor.
Thank you.
How's everyone here practicing testing? Are your surgeons sending testing? Are you sending it? How's the workflow working out?
We pretty much, our practice, we pretty much send most of the patients with NGS testing or immunotesting. But one of the questions I'm just asking you, sometimes our surgeon, before even refer patient to us, he had surgery, resection, then also send the NGS testing for kind of like a Oncotype DX. There are different companies offer this kind of service. Some of the surgeon orders this test, come back is a high risk for recurrence or distant or local recurrence. But when the patient referred to us, we see this patient like a tumor like 2.1 centimeters, adenocarcinoma, completely resected. But we face a dilemma, have to explain to the patient very in detailed way and also communicate with the surgeon. Do you guys order this kind of testing for adjuvant?
For lung? No, we don't.
Correct. There is a few publications. It's small case numbers. It's not really that many. So I have to call the surgeon, talk to them, say, hey, please don't order this kind of test. It's going to be put us in very difficult positions to how to explain to patient. But the patient already kind of like have idea before even come to see us. Said, yes, Dr. Chen told me I have high risk based on my gene testing profile. I need chemo. That happened.
Yeah, no, I'm not aware of the efficacy of such an assay in the lung cancer setting. I think obviously companies would want us to use these products, but we haven't been using them.
Yeah.
So do you use any ctDNA guided therapy in clinical trials?
We don't know the correct platform of ctDNA guided therapies. We're certainly thinking about that in clinical trials, but we don't really have a good MRD assay that's been validated. We have so many questions. Does it have to be tumor informed or tumor uninformed? What kind of depth do you need? What kind of sensitivity? What kind of coverage? What are the time points that you use it at? I don't really think it's feasible for us to just say, I'm just going to use a Guardant because it just hasn't been validated. So we haven't been using it in our clinical practice. I think we're just waiting to actually incorporate it in some intergroup trials as we speak.
So you don't do any MRD testing?
I don't know which one to do. Do you have any suggestions?
No, we've been trying this Signatera. That's the only thing. And then Guardant has some tests. Yeah, like you said, we don't know what to do with it.
So
Yeah,
Dr. Vokes,
Signatera is probably,
I was going to say, Dr. Vokes is giving a talk tomorrow night on the ctDNA data at MD Anderson. I'll send you a link.
Yeah.
Dr.
Okay.
Shar, any trials looking at combining immunotherapy and EGFR agents for EGFR mutated patients that you're aware of, or anything efficacy along those lines coming up?
in the metastatic setting?
No, early stage.
No, not that I'm aware of.
Okay. But metastatic, you are seeing the up and coming.
Yeah, so
Combining.
Flora 2 will come out probably at either World Lung or at ESMO, which is first line combination chemo plus osimertinib compared to osimertinib alone. we'll see. The press release said that it was a positive trial for PFS, I believe, but we don't know what that improvement is and what it looks like. So we'll be curious to see.
Okay, well, we'll go ahead and wrap it up there. Lots of good questions. Thanks everybody for taking the time out of your evening to join Sharu for the talk. And until we meet again, I hope everybody's enjoying the summer.
Thank you.
All right. Have a
Take
good
care,
night,
everyone.
everyone. Thank you.
Thanks
Thank
so
you.
much. Appreciate it.
Thanks very much.
Appreciate
Thank you. Okay, bye-bye.
Bye-bye.
Good night.